Hello, everyone. Great to get to be with you here on Tuesday, January 27th. I love our time together, and I'm going to look forward to this. I know I am. I'm Mike Ackerman here with you from Mayo Clinic in the tundra. There's my coat. I walked into work, as I do every single day. And the other day, on Friday, I had come back from our Mayo Clinic cardiology meeting in Puerto Vallarta. And that morning, my walk into work was minus 21 real temperature. And the outdoor temperature walking to our meeting in Puerto Vallarta was plus 69 at the same time. So we had a 90-degree temperature gap from Mayo to meeting. And that's my record, I think, in terms of the most extreme. But never fear, put a coat on. I love this weather and don't mind it. But I'm looking forward to seeing patients and colleagues next month for the month of Florida on our Mayo Clinic Florida campus. And speaking of next month, as you know, February is National Heart Month. And you'll be hearing from us at the SADS Foundation about all things the heart, how you can participate, what you can do, how you can give. Imagine that. You too can give for the new year. Top right corner, donate now, www.sads.org. So good to be with you. I can't wait to get into your questions. So let's get into your questions and see what they are. And I'm looking on the sidebar. And here's the first one of the day. And great to have it from Malgorzata. And reminder, keep your questions tight and short so I can glance quickly. Remember, I am never giving direct patient-specific advice. There's no way I can do that based upon a quick question. Typical evaluation in our program is 90 minutes. So this is not direct patient advice, but I try to take your amazing questions and dissect what are some of the important elements and issues at hand that would be generalizable to all of us. And with all of us in the SADS community, some of the answers aren't going to be relevant to your world and your disease at all. So keep all of that in mind as we get back to Malgorzata. What if I have none of the 17 known LQTS genes, but my QTC is sometimes prolonged? Does this imply a yet unidentified genetic cause? I love to start our SADS program, SADS 175, with your question, because what I like about it is we know a lot about the genetics of long QT syndrome. In fact, we have more of long QT syndrome genetically captured than any of our SADS conditions, any of the others. Meaning, if you truly have long QT syndrome, that genetic test that we currently conduct should catch about 90% of long QT syndrome. So is it possible that I have long QT syndrome and am negative for the known genes and have so-called genotype negative long QT syndrome, or also called genetically elusive long QT syndrome? Yeah, that's possible. In fact, about 10% of my patients do. On the flip side, when that test comes back negative, that genetic test, thereby ruling out 90% of all long QT syndrome combined with one test, then the rest of the evidence, the story, the setup, the situation, the ECG data for calling somebody genetically elusive long QT syndrome better be really good. And in general, for most of the patients that I have seen under the diagnosis of genotype negative long QT syndrome, after further review, we have said, no, the evidence to call you long QT syndrome in the first place was weak, too weak. In fact, sometimes so weak that we wouldn't have even advised genetic testing in the first place. So in your case, with a negative genetic test, one needs to look at all of the data very carefully and say, despite the negative genetic test, am I still going to call you long QT syndrome? If so, yes, I've done that. I do that. But the evidence better be really good. Great question to start it off. And we turn to Lindsay's. What are my thoughts on playing football? My 11-year-old son is controlled on Nadolol and Mexilatine with an SICD. He really wants to play, but I'm torn. Well, Lindsay, I love the question. And in a way, that question might have had different answers 10 years ago, 20 years ago, 25 years ago. For my program, the answer has always been the same. And that is, for every patient of mine, whether they're an artist, athlete, academic, I try to figure out what's their love. And I would ask your son, in terms of football, is this O oxygen or is this O optional? And for all of my athletes who give me an O optional, it's like, why would we even take on any risk for something that's optional? For the others where it is their oxygen, and many of my athletes, when I say on a scale of 0 to 10, 10 being I gotta do it, what's your desire meter at for returning to the sport for which you've been disqualified or been in the penalty box? And they'll say, oh, well, can I say a 12? And so for yours, for me, I would have zero fear of football as it relates to the diagnosis or the presence of a defibrillator or any of that stuff. Now, as to football for an 11-year-old, I'm reminded of my son my oldest, now 33, when he wanted to play football, I said, you're going to get crushed. He went out for it in 8th grade, 7th grade, got crushed on a punt and switched to the other football, the real football, soccer. And so far more likely for concussions to occur and other issues in football than concerns about the heart and that sport. So I'm not torn. Hopefully this helps you weigh the risks and the benefits in the balance. Mel's asking, what would be the safest way to treat low testosterone for someone with Brugada syndrome? And there, that question brings out the awareness that why is it that in men, adult men after puberty with Brugada syndrome, pound for pound, the expression or the declaration of Brugada events is about 9-to-1 ratio, 9 parts men, 1 part women. So there's something pro-arrhythmic about testosterone in the Brugada host that's not present from estrogen. And we know that. We kind of know the mechanism and the why, the biology behind that. So does that mean that every man with low testosterone cannot have any sort of testosterone supplement if they have Brugada? And my answer is it depends. And it depends on what kind of Brugada are we talking about. Is it obvious Brugada? Is it already declared Brugada where they already own a defibrillator? And now I'm not so concerned about doing some sort of testosterone supplement. So a lot of factors have to be weighed in the balance there. But have I used it in some of my Brugada men? Sure, I have. Michelle from Instagram, from that streaming social media platform, stating that she has AVNRT. That's not really a genetic heart condition, atrioventricular nodal reentry tachycardia, and she also has type 2 long QT syndrome. And wondering if can any of the episodes of her AVNRT trigger her long QT? Great question. The two almost never coexist. So, and there's no relationship, meaning there's nothing about the long QT2 mutation that makes it more likely for somebody to have AVNRTs. On the flip side, there's nothing about AVNRT, which is far more common than long QT syndrome. Type 2 long QT syndrome probably is a 1 in 6,000 person occurrence. AVNRT is probably, you could fact check this for me, but maybe 1 in 100 to 1 in 200 people have AVNRT, probably closer to 1 in 200. So that means that 1 out of every 200 of my LQT2 patients might also have AVNRT. Maybe it's not quite that, because I don't have hardly any LQT2 patients or long QT patients for that matter with concomitant AV-NRT. But can they coexist? Sure. What we've called in medicine lice and fleas. Two things can coexist having nothing to do with each other. Now, could the one aggravate the other? Specifically, could an AV-NRT trigger an LQT? Great question. Almost for sure, no, because there's nothing about that top chamber arrhythmia that ought to be QT triggering. Now, if you're having symptoms from the nuisance rhythm issue from the AV-NRT, then maybe you need to see that heart rhythm specialist about therapeutic ablation for the AV-NRT. Next question. Hello, back to Bhakti. Giving me a greeting is from Terry, who has ARVC, remember, arrhythmogenic right ventricular cardiomyopathy, and her doctor cannot view the structural damage during an MRI due to the ICD. What other assessments do you recommend? Oh, good question. Honestly, if I have a patient under my watch with ARVC where they already have an ICD, I don't really need the MRI any longer. The decision's been made, so it doesn't matter how much scar or fibrosis there may or may not be. So now I would be using primarily the echo as my imaging modality to assess the strength of mechanical health of the RV and LV, and I'd be using your symptoms. How are you doing as to whether there is progression on the mechanical side of the equation, because I've already addressed and countered the electrical side. Now, could we do an MRI in somebody with an ICD? Absolutely, we do that all the time. And we even do that whether or not we have a so-called MRI compatible defibrillator. If it is MRI compatible, it's a lot easier. If it's not, if it's an earlier generation, we just have to do more work with our cardiac radiologists, the physicists, and so forth in terms of monitoring the device and the lead. What's my opinion on moving to exome and genome for higher yield over traditional panels? I think right now still, all of the companies who are providing commercial genetic testing for long QT syndrome, ARVC, Brugada syndrome, their panels are great. They use next-gen sequencing platform. They use catchment of exome data, mostly exome data, not necessarily genome, as their data inquisition, and then they do their analyses of the genes of interest. So I personally would still do the panels. For my elusive families where I'm convinced that there still might be a genetic mechanism in play, then we will turn and focus our energy with the genome, and we'll do what's called a whole genome trio, where or the family study with gathering the genome to try to find that family's new gene, new cause, new reason. But for starting point under commercial testing, I almost always start with one of the commercial test companies' existing panels. Kayla, well, hello there, Kayla, who has CPVT. That's catecholaminergic polymorphic ventricular tachycardia. 2/3 of the time, remember, due to mutations in the RYR2 built ryanodine receptor. And she takes flecainide, that's one of the heart rhythm medicines, and Nadolol, one of my favorite beta blockers. And then her primary has prescribed her tirzepatide and told her that there was no contraindications. And however, taking it, randomly called a test that I was to see how I metabolize flecainide. Is it safe to take these medications together when tirzepatide slows how long you metabolize food? Almost no problem with that medicine. Tirzepatide, remember, is one of the so-called GLP-1 agonists. It's used for weight loss. It's used in type 2 diabetes. It's used in heart failure. It's one of the new generation blockbuster medications. I now have many patients using these, benefiting from these. The weight loss has been incredible. And they have no QT agitating effect. I have not seen it. They have no proarrhythmic effect that I've seen. Now, the metabolism issue is, as Kayla correctly remembers, flecainide is metabolized by a particular enzyme in the liver called the cytochrome P450 2D as in David 6, 2D6. And some of us, not very many, but some of us, 5%, are either ultra rapid metabolizers of flecainide because their 2D6 enzyme just grinds through it, or we're ultra poor metabolizers because we have a wimpy 2D6 enzyme. And that would influence how I would dose and use the flecainide. Some I might need a much higher dose than what you would have guessed. Some I may be able to use it just once a day because they're a really slow metabolizer. Now, tirzepatide, I'd have to look it up. I don't know it off the top, what enzyme that it uses for its metabolism. So the only issue at hand for a drug disease or a drug-drug interaction would be if by chance tirzepatide also uses the 2D6 enzyme for its metabolism. And I'm pretty sure that it does not, but I don't know that for a fact. I have not looked that one up to confirm that. And so that's one we would have to review and verify. I don't believe so. So I think there is no issue. Gianna is wondering, how does SADS collect any blood samples for research? Great question. The SADS, as our foundation, we do not collect blood samples. We at SADS are not a biorepository of samples. What we do at the SADS Foundation is direct a family to research-based genetic testing, if that's indicated, like my lab at Mayo Clinic, the Winland Smith Rice Sudden Death Genomics Laboratory, is devoted to finding your why. What is your cause when the current test panels are negative? And that assumes, of course, that the diagnosis is correct, legit, and we're really dealing, as we said at the first question, with genotype negative long QT syndrome. Then we try to partner with that patient, now a research subject, to find their cause. But as a foundation, the SADS Foundation, we do advocacy, we guide, we direct, but we do not collect samples. CJ is asking, is it typical to have arm shooting nerve pain in your armpit 6 weeks from post LCSD for CPVT? It doesn't matter the disease, whether the surgery was done for CPVT, long QT, ARVC, which we've done, and other diseases that have a clear adrenaline trigger. That post-denervation complication of neuropathic pain, which can include the shooting nerve pain in the armpit, 6 weeks, have no fear, it's still going to go away. It's not uncommon. Now, how often do my patients have true neuropathic pain? I would say it's about 5 to 10% at most. Will some people have a reminder spot right here over the left scapula about the size of a quarter as a referral pain for a bit? Yeah, in almost all of them, it melts into the woodwork. So that kind of pain is so temporary that I don't really even call that the post-denervation nerve pain. True neuropathic pain starts about 2 weeks after the surgery. And those who are that 5 to 10% group, they will have it in the left armpit, like you described, down the left tricep and down into the side, sometimes around the crease of the left breast tissue. And it's a whopper. There's no sugarcoating it for those who get that pain. Now, it goes away in almost everybody. Interestingly, my athletes are almost never recipients of that. It's not the same by age across the board. It's not the same men or women. Women are more common to experience it. Men are less. not all or none. And then I've seen, and we've seen quite strikingly, that 5 to 10% grouping is more occupied, disproportionately occupied, by those who've had a variety of pain sensitization phenomenon during their life. Chronic fatigue, fibromyalgia, everything hurts. It always hurts. And if that's kind of how a person is wired before the denervation, they're more likely than not to experience that nerve pain phenomenon. Good news, it goes away in almost everyone. Sometimes we use nerve pain modulators like gabapentin, for example, to try to accelerate the healing of those nerve endings. Most important activity that you can do besides the choice of do you or do you not need a trial of that medicine is to stay active, to get the mind off of that, to press through it, because it does go away. Daniela, are beta blockers still being the first line treatment for type 8 long QT syndrome only? Short answer, yes. The vast majority of my patients with calcium channel mediated long QT syndrome, also known as LQT8, and when it's the heart only with no features of head to toe phenomenon, syndactyly and so forth, of Timothy syndrome for the LQT8 version, and for the cardiac care of the Timothy person, my first line drug is still beta blocker therapy. Carr from Instagram. Instagram is a hot source today. You're winning as the platform. In a previous episode, I indicated that boys with LQT2, it's better to take beta blockers at night. Do you still recommend this? Should I speak to my cardiologist? Appointment is scheduled with you in March. Look forward to seeing you in March. And the timing of the medicine is an interesting one. And we have a really cool paper coming out where we have examined the so-called circadian rhythm of breakthrough episodes on medicine of patients with their LQT1 or LQT2 or LQT3. Can't share details. It's embargoed so far, but it's changing my view as to how I was doing therapy, meaning after my patients who are old enough to where I can switch them to once a day beta blocker, and I generally do once a day beta blocker with Nadolol or long-acting propranolol at around age 8, 9, or 10. So let's take a teenager. I was trying to outsmart the system by having the beta blocker be taken at morning with breakfast if you're LQT1, because after all, most episodes occurred during the daytime. And that turns out to still be true. Then for my LQT2 patients, where we had awareness that their episodes occurred mostly during the night, during sleep, during 5 a.m. arousal from sleep, it seemed to make better sense to encourage them to take it at night. Well, not so fast, and maybe not so necessary, because that circadian rhythm would, before you get diagnosed and before you get treated, nighttime arousal, early morning events may not be the same time of events after diagnosis and after treatment, such that I no longer feel that nighttime dosing for LQT2 is mandatory. Now I switch it to what time of the day is the time that you will almost never, ever forget. If that's morning breakfast and you're LQT2, do morning breakfast. If that's dinner time with LQT2, do dinner time. Taking it faithfully, not missing it, is far more important than did you take it at 8 a.m. or 8 p.m. So no need to change things around based upon what we said before, because it turns out we've learned something new. Shay is asking, what are the compelling diagnostic criteria for gene elusive long QT syndrome? Meaning, my test has come back negative. How sure are we that I even have long QT syndrome? Well, they're the diagnostic criteria. Some of you have heard of the so-called Schwartz score, developed by originally Moss, Compton, and Schwartz, dear friend Peter Schwartz and the late Arthur Moss, and a series of clinical criteria, ECG criteria, family story criteria that, depending on how many points you achieved, then you would have a so-called high Schwartz score. And so if you had a high Schwartz score, scoring 3 points or 4 points, and the genetic test is negative, then you are genotype negative, Schwartz score positive, long QT syndrome. But it really starts with the story. If I don't like your faint, your cardiac arrest, so we have points for the story, and I don't like your ECG, I don't like your QT interval, now we have ECG points. Well, you're genotype negative long QT syndrome. It just turns out that most often it's been a situation where maybe there was a premature rush to QT judgment. Maybe people were just simply called long QT syndrome a little too quickly on a little too flimsy set of electrocardiographic data. And moving on, wow, the questions keep on coming. I've got to pick up the pace because we're 14 minutes or less on our counter together. Mandy is stating that she has low cortisol, low adrenal and adrenal gland fatigue, and LQT2. I was told to take a supplement, ashwagandha, to help, but I'm hesitant because I don't know whether it could trigger. Is there evidence of its safety? Well, there's going to be definitely no evidence of its QT-related safety. There's just not enough patients with long QT syndrome on the supplement ashwagandha followed for any length of time to declare true safety of that supplement in that setting. Having said that, I don't see anything about that supplement that makes me QT concerned, where I have never preemptively told patients, please do not take ashwagandha. Whereas for some of our long QT patients, I have told them, please do not drink a lot of purple grapefruit juice. Or I have told them, please do not drink highly caffeinated energy drinks, such as found in Monster, Red Bull, 5 Hour Energy, Celsius, and so forth. Because those highly caffeinated energy drinks, I have seen pro-arrhythmic episodes. I've seen diagnoses of being made, and we've published a tragic series of some sudden deaths in the setting of those exogenous exposures. Now, many other factors. Was it the only thing to blame? Almost for sure not. Could it have been part of the perfect storm? Yes. Is there any redeeming health benefits from it? Not a lot. So easy for me to advise those, but I have not ever added ashwagandha to my list. Kayla's back asking about the role of that GLP-1 agonist with respect to CPVT. By itself, I have no concern about that GLP agonist, that weight loss strategy in somebody with CPVT any differently than I have no concern in somebody with long QT, ARVC, Brugada, any of them. Christy, and speaking of caffeine, asked me, what do I think about using coffee instead of other pharmaceuticals for ADHD if your child has LQT2? Curious about this option with coffee being a stimulant. I think, great question. First of all, I have not found any reason to be concerned about any of the ADHD related therapies in my patients with long QT syndrome, in my patients with CPVT. Do those therapies reside on the www.credible.meds.org QT hit list? Yes. There are loose association in terms of they're not guilty as charged. They're indirectly there because they are quote unquote adrenaline-like. The reality is, the data is, our experience is that in a diagnosed and treated patient for their long QT, diagnosed and treated patient treated for their CPVT, the concomitant treatment of their ADHD with medicines on that list, of their anxiety with medicines on that list, of their depression with medicines on that QT hit list, the risk signal is almost non-existent. You can never declare zero, but the risk is so low that I think the risk-benefit equation in a patient who truly would benefit from ADHD therapy is there. Now, are we overdiagnosing ADD? I'm not a specialist in that. I can't speak to it. Does it make sense that 7 to 10% of all kids are being diagnosed with ADD, ADHD? We'll let the behavioral specialist weigh in on that. But for a family where that disease or that diagnosis is wreaking havoc on quality of life and non-pharmacologic strategies are not working, do I have fear with the use of those ADHD medicines? And you can name them. It doesn't matter their name: Ritalin, Concerta, Terra, Vyvanse. Am I forgetting any? It doesn't matter. So I work with the behavioral specialists and say, for what you are observing, which treatment have you seen the best efficacy with? And if they tell me Ritalin, I say great. If they tell me Concerta, I say great, because I don't have a QT fear. I don't have a CPVT fear about. Now, can coffee do the trick? Probably not. The duration of activity with coffee as the stimulant is dramatically different than the duration of activity with the direct FDA-approved medications for ADHD. Love the question. Thank you for it, Christy. Well, Brugada one. We haven't had a Brugada. Well, did we? Oh, we did. We had testosterone. But Lydia is asking our second Brugada question of the day. I have type 1 Brugada with spontaneous ECG that is present most of the time. My genetic testing was positive for a variant of unknown significance. Oh, we needed to have that VUS, didn't we, in the SCN5A gene. I have a pediatric cardiology appointment coming up for my 8-month-old and 11-year-old. When would I recommend genetic testing on them? Ooh, awesome question. So first, it sounds like that I'm dealing with a correct electrocardiographic diagnosis of Brugada pattern. So she has the type 1 Brugada pattern by description. Does that equal Brugada syndrome? Actually, not in my book. She has the pattern. Now, could that be due to Brugada syndrome? Yes. So how would I make it from a pattern on an ECG to a syndrome in the family? Well, if 2 relatives own that pattern, then it's the syndrome. Maybe not a symptom from it, but it's the syndrome. If she owns that pattern and she has a positive genetic test, that's a syndrome. Genetically mediated Brugada pattern is also known as asymptomatic Brugada syndrome. This all assumes, of course, that she still has never had a symptom. And then we turn out that we have something, a thingamabob, a whatchamacallit, in the one gene that is a irrefutable Brugada gene, the gene SCN5A, that builds the sodium channel in the heart. And we know that loss of function mutations in that gene is responsible for about 20% of Brugada syndrome. So how do I move this needle about this VUS? The company, or a company, the genetic test company, has called it a variant of unknown significance, or a VUS, by their tools. What would I call it? And that depends. I'd have to look at the data. I'd have to stare at that VUS. I'd have to do my search about that variant. And then I would want to determine whether I agree with that designation and say we're stuck, it's kind of ambiguous, or if I would say, you know what, the company's called it a VUS, I do not. I call it a Brugada mutation. The moment I say I call it a Brugada mutation, that's the moment that the kids should be tested. Why not test them? Why not figure out who is positive 50-50 chance and who is negative 50-50 chance for that genetic marker, so I know what kind of a surveillance strategy, what kind of preventative measures to set in motion for that child, whether that child's 11 or not yet 1. The age doesn't matter to me. If we don't want to be tested yet, do we get an ECG to look to see, do they show a Brugada pattern like mom? Of course we do. We must. because now I can't be influenced by the presence or absence of the genetic marker because we haven't gotten it. The other thing that would help me move the needle is staring at your ECG and saying, besides that Brugada pattern, what is the PR interval? Because in patients who have true SCN5A Brugada, they often will show a prolonged PR interval also, such that if I have a patient with PR prolongation and a Brugada pattern, and then I order the genetic test, the SCN5A positive rate is not 20%, it's actually 40%. Whereas on the other hand, if I order that same test on somebody with a normal PR interval, the yield of the Brugada genetic test for SCN5A drops to under 10%. So now think about it. If Lydia's PR interval is greater than 200, she has an a priori likelihood of 40% that it's going to come back SCN5A positive. On the other hand, what if I just randomly order the SCN5A spell checker on all Caucasians? 2%. 2% will have a Brugada, an SCN5A thingy. It'll be called a VUS almost certainly. So that's 40 divided by 2, 20 to 1, also translated as 95% likelihood pre-test probability that that's not a VUS, that is the cause. So without even hearing the genetic test report result for her, if I actually knew what the phenotype was in more detail, what's the PR interval, I would be able to move that VUS needle. And that is the exercise that anybody who's ordering genetic testing for these conditions should be doing. They need to be decoding the genetic test result, not just reading the company's report. I think that's going to be our last one. Although, let me quickly grab this one from Katrina. We can do it because it looks, she gave me a great short, tight question. Is magnesium okay to take for patients 60 and over with LQT2? Is collagen safe? Yes and yes. I have no downside that I know of for magnesium. Do we need to take magnesium? No. If the magnesium level is normal in the body, does taking magnesium supplement do much besides spend money? Probably not. But it's a safe supplement, no concerns with LQT2 or any other of the other SADS conditions. And collagen is safe as well. And last question, and Jessica, I wish we could grab it. It's a really, really good one. It's a little bit long. And I'm at on 58 on the counter. Jessica's kids are 6 and 8. They just tested positive for DSP. That's the gene that builds the protein desmoplakin, one of the genetic types of ARVC. She was diagnosed last year, had a high troponin. She's feeling good, waiting for her own ICD. The kids have appointments at Cleveland Clinic in 2 weeks. I say hi to my friends there. One of my favorites, Peter Aziz, is there. Just wondering what I should watch out for, where to go and what to do, as they are both big in sports. Well, the wait will soon be over. You're going to be there in 2 weeks. You'll be in great hands there. If I can be of any help, do not hesitate, but you'll be in great hands. In my program, I have lots of patients with positive ARVC genetic test results who are not showing the disease yet, may never be showing the disease, and they are living and thriving doing lots of different sports. So live and thrive is the key, and we will go from there and pick it up our next time that I get to be with you in February. Be on the alert for February. It turns out that the calendar is crazy in February. We're going to do a time shift for my Tuesday with you in February. Aaron will share that with you. And so until that time, have a wonderful rest of January. The first month of the new year's almost in the books already. Amazing, crazy. Be well out there. Live and thrive out there. Be anxious for nothing as best as you can. Blessings to all of you. So we'll see you next time.